Okay, I think we are all set now. A very warm welcome to this 188th edition. We had to change the topic and speaker last minute due to our original speaker falling ill. So we'll have that topic probably after 15 days. So today's topic is family therapy in Indian settings. Next slide, please. Handing over the session to our chairperson, Professor Dr. Tufan Pati sir. Sir, over to you.
Thank you, Ali. And thanks for omitting details. Next slide, please. By the way, welcome our moderators and the IPS office bearers, Dr. Alim Siddiqui and Dr. Amrit Pakadursi. They have been here with us.
Dr. Vishal also.
And we have got new moderator, enthusiastic moderator over few episodes. Dr. Vishal Chabra from Delhi. Welcome you all three. Next, please. Delete the series of everyone. Go to the chairpersons, please. आशीष जी थोड़ा और आगे चलिए. Our chairperson, Dr. Ranjan Bhattacharya, who is also not new, who is quite frequent visitor of this museum platform, is affiliated as Professor, Department of Psychiatry, Bankura Sammelanini Medical College, West Bengal Medical Education Services, Director, Cherak Square Diagnostic and Research Center, Visiting Consultant, Ruby General Hospital, Media Super Specialty Hospital, Narayan Memorial Hospital, and Remedy Medical Services Private. Areas of interest and specialization, addiction psychiatry, sexual medicine, child and adolescent. He has got 61 publications, and the awards he has received: IMA Dr. R.N. Murthy National Award in Psychiatry for 2019, 20 and 2021. Winner BPSSA IDCM Award. Organizational position, Honorary Joint Secretary, IMA Bengal, and Associate Editor, CIMA, Editor BJP. And he is Vice Fellow, American Psychiatric Association, and Indian Psychiatric Society, Indian Association of Private Psychiatry, Indian Association of Pediatric Mental Health, Indian Association of Biological Psychiatry. Sorry for the interference. There are calls coming and that's why silence. Next one, please. Dr. Rukseda, vibrant psychiatrist, psychotherapist, founder of Trellis Family Center, Lokanwala, Mumbai, specialties, adolescents, young adults, women and families. Very much well known, Dr. Wells Rukseda Saida. He is President-elect of Bombay Psychiatric Society, Vice President, Indian Association of Biological Psychiatry, advisor led by Foundation Family First Guidance Center, Committee C11IWA. Studied and trained at MBBS from Lokmanya Tilak Municipal Medical College and Hospital, Saya in Mumbai, with psychiatric training at GS Medical College and KM Hospital, and WHO Fellowship in Psychosocial Rehab from South Korea. Author, media expert, TEDx speaker, Passion Project, YAMI, a support group for young adults. Fun facts, loves to laugh, cancer. Welcome, Dr. Rukseda and Dr. Ranjan.
Thank you so much, sir.
This meeting now belongs to you, and someone will introduce Dr. Vinas, who is very much well known personally as well as on this platform, and to this session on the family of Thursday Musings to speak on the family therapy. Over to the chairperson, and someone will introduce the topic. Someone will introduce Dr. Vinas.
Thank you, sir. So I think I'm going to take the prerogative of whether you want to call it gender, beauty, or age, and go ahead and introduce the topic, and then I will leave the pleasure of introducing Avinash, not that he needs any introduction, to my able colleague, Dr. Ranjan. So family therapy, that's something that we hear about, talk about, read about, but how much do we actually end up doing in our day-to-day practice, especially whether we are talking about a busy private practice or whether we are talking about the poor resourced public healthcare services. But it does remain an integral part and a very important, essential aspect of the treatment plan, the management that will definitely impact outcomes. Whether we're talking about family therapy from, how to improve relationships, interpersonal relationships, family, which might be a life skill, or whether we're talking about family therapy because one or two of the members may be unwell and the rest of them might not be primary caretakers, but would be maybe supportive as well, and how those interactions could change and again impact outcome not only of the person who might be suffering, but also reduce risk of other, especially family relatives who might have more of a genetic loading. So again, how many of even unfortunately, because of the way things go on, maximum that we reach occasional family therapy is a psychoeducation session, probably. But we definitely want to know a little bit more, and who better than Avinash to give us a little bit more tips in terms of practical application on a day-to-day basis as well, and how do we encourage more family therapy, how do we see the benefit of it, and also hopefully also do a little bit more research in family therapy. So with that, I'm going to thank the organizers for having me as a chairperson for today. Thursday musings are really, really popular. And, just by the number of attendance that we have on a weekly basis, that shows that there's a genuine thirst for knowledge and information and improving our clinical acumen, which bodes really, really well for the future of psychiatry in India. And with that, I am going to hand it over to my co-chair, Dr. Ranjan, who's going to go ahead and take the session forward. Thank you so much.
Thank you, Dr. Rukshada. It is my proud privilege and honor to be the chairperson in this session. It is amazing how the Thursday Musing has now crossed the 188th edition proudly, with the 77,260 participants throughout this journey. So today I'm really indebted to Dr. Tufan Poti sir, who is the series chairman, and the able moderators, my best buddies, Dr. A. Malim Siddiq, Dr. Amrit Pattojoshi, and Dr. Vishal Chabra, for inviting me to be the chairperson in this masterclass in therapeutics. So today, going to introduce the speaker, Dr. Avinash D'Souza needs no introduction. He has done MD, DPM, MS, MBA, MPhil, and Psych.D. Research Associate at the Lokmanya Tilak Municipal General Hospital and Lokmanya Tilak Municipal Medical College. So he will be delivering the topic, the family therapy in Indian context, and the context of this topic has already been described by Dr. Rukshada. So without much ado, I'd like to hand over the session to Dr. Avinash D'Souza. Dr. D'Souza, the stage is all yours. Unmute yourself, please.
Someone has to share my slides. I think whoever is going to share, yeah. Okay, so while we talk about family therapy, I just want to sort of make a few disclaimers that today's session primarily is more about how we look at sessions with families, because I think we may not really do family therapy in its core sense, but a lot of us in our day-to-day practice are looking at families as a whole. Next slide, please. You'll just have to keep clicking till the slide ends, because I think there's an animation which is at play. I'm sorry about that. So the thing is, I'm a psychiatrist and I work with families, I see families. Why are we having this lecture? Because we're going to look at family sessions, how family sessions matter. And the aim of the present talk or training is not to teach you family therapy per se, but how do we handle family sessions in our day-to-day practice, which is very important. And we're going to learn about primarily how do you handle people in family sessions. So you will have psychoeducation sessions, you will have a few counseling sessions, you may have sessions with half the family, with the entire family, with regard to diagnosis, acceptance, treatment compliance, multiple things. And you learn also about psychopathology when you deal with families. So that is what I intend to do. Do I practice family therapy? No, but I practice family sessions. So this is a fun fact that family, yes, they drive you crazy, they drive you nuts, they even drive you loony at all. But the most important thing is they drive you. The family is what remains with you, whatever happens. So the thing is, we go to the next slide. Yeah, so there are some critical issues which we have to consider. You'll have to keep pressing. I'm sorry about that. So the critical issues that we have to consider is what exactly constitutes family therapy. Now, as per the textbook definition, you have the entire family that comes for sessions. You may speak to them one by one. You may speak to them in a group. You may have multiple sessions with them. You may have sessions with some parts of the family separately, the others separately. And this is a process that takes a few months, particularly when you feel that the families are causing turmoil to the patient, particularly when you feel that the family is causing stress. Now, the important factor here is, how do you define a normal Indian family? This is something which is a very, very difficult thing to do. We really don't have a definition for what is a normal Indian family. We always believe that, I mean, people, when they use the word Indian, they have different concepts. They believe there is one breadwinner, there is a homemaker, there are children. There is another concept where you have both parents who are working and you have children at home. There are some people where the parents are here, the children are studying in another city. So there are multiple different things. So there's really no definition for a normal Indian family. So it's very difficult to sometimes, understand what do we mean by a normal Indian family. And we see so many different types of families, family constellations in India, that there's really no one definition. Next, please. And we need to look at family therapy in the Indian context. Let me tell you, one of the most difficult things with regard to family therapy in the Indian context is to get the entire family to come. Because invariably, I mean, one of the persons is working, one of the persons has an evening shift, one of the persons has a morning shift. So you never really get the entire family together. That's the most difficult part. So, you fix a session, you have to fix a time that suits all the 3, 4, 5 members, all have to be there. And this is something which is the most difficult part in family therapy sessions. You can do it online in today's era, but it's always better in person, because there's a lot of more discussion that can happen, and online can sometimes get a little difficult to control. Next slide, please. So what is very important to understand is that families sometimes may predispose a person to psychopathology. When I say this, what I mean is that families may be the cause. So we have a number of patients that we see in our practice where we know that bad parenting, bad childhoods, bad emotional interactions between their parents, sibling rivalry, joint families where a child is compared, some sexual trauma that they've experienced from a close family member. So very often families could predispose a person to psychopathology. Next. We have also seen that sometimes families may play a role in the maintenance of psychopathology. What we mean by this is that sometimes you have families who, even if a patient is ill, I mean, rather than working towards a cure, they may shout at the patient, degrade the patient, make him feel low self-esteem wise, may not understand that the patient has a problem. They may taunt the patient. Sometimes it can happen that somebody, if you have a patient who suffers from alcohol dependence, some family members provide him with alcohol and do not let the problem come to a halt. Sometimes families refuse to accept that there is psychopathology present. So as a result, the psychopathology just continues. So sometimes families may play a role in the maintenance of psychopathology. Next slide. Next. Yeah. And what is very important is that families may transmit psychopathology across generations. So we see a lot of families where there's a family history of depression. The grandfather had it, the father had it, now the son has it. The father has had ADHD and learning disability, nothing was done. Now the son has it, nothing is being done. There is domestic violence and aggressive behavior which runs across families, which is culturally acceptable in some cases. There is substance abuse that runs in families. So families may transmit psychopathologies across generation, and the same is true even for some personality disorders. Next slide. So what are the different types of families we see in India? The most common type of family that we see is a nuclear family, where we probably have a husband, wife, and children. And it's not that there is any particular type of family which is more predisposed to psychopathology or more free from psychopathology, but I'm just running through these families because these are all the types of families you will encounter in practice. We also see joint families where we have multiple small families staying together. So you have brothers staying together, you have grandparents, you have children. So this is a huge family constellation. This is slowly dying out, but it's still there in most states and most parts of India. Then we see single parent families in our practice where a divorce has happened. One parent is living with 1 or 2 children, and you have a parent that is visiting because he's the divorced parent. You also have the mother or the father who is also having someone else in their life who's also part of this family. So you have one parent families that come into play. Next slide. Yes, then you have adopted families where families adopt a child. Why I call them adopted families is because they very often adopt a child, and during the period of child development, there's a lot of psychopathology that may be seen in the child, right at a young age. It may be seen at teenage years, it may be seen in adulthood. And the families definitely know that they're not biologically the cause, but they often wonder where the psychopathology has come from. Our parenting was good, everything was good. And this is a big challenge in our practice. Next slide. We also see some communal families. When I talk about communal, I don't mean religious in any way. When I mean communal, these are families that have very strong beliefs. They have either strong beliefs in certain methods of treatment, so they'll go to faith healers, they'll go, and they are refused. They have total disregard for psychiatric treatment. So they're communal in that regard. Then we have reconstituted families. When I mean reconstituted, families that broke off, then again came together. So they've had periods where the family has been broken, and then they've come together for the sake of the children, or they've come together. So we have these kind of reconstituted families also. And then, of course, we have spread out families. The husband is working in Dubai or Qatar or Middle East or Europe. The mother is here. The children are, one is studying somewhere in North India, one is studying in South India, mother is in Bombay. So these are what I call spread out families. They are spread out all over. They meet only for vacations, or they meet on certain periods. But the entire family is never together, but they are they're in touch online. Next slide. So there is a lot of polarity in family therapy. When you look at families and when you call them for counseling, either you have families that have individuals that have their own thoughts. So these are individuals who are totally strong individuals who have their own thoughts. Each one has their own way of thinking, and no one wants to give in. No one wants to sort of, say, okay, I will be the one who will adjust. In addition to that, we have enmeshment. And enmeshment is a concept where there is a sort of too much of the family is too much into each other. They are fighting also, they are in love also, they are taking care also. So there's too much of enmeshment. And enmeshment results in emotional contagion, it results in aggression, it results in bickering, it results in fighting. So you see this kind of thing also. Next slide. Then you see mutuality versus isolation. So you see a family which is very strong together. So they come, they say, our son has depression, we want him treated. Our son is suicidal, we want help. The entire family has come. They are ready to do whatever is needed to be done. They are cooperative, they are adherent to treatment, they are compliant. So there is no problem that way. And at the same time, we also see isolation. So the entire family is isolated. The mother has brought the son for you, and they'll tell you that he has a brother, but he's aloof from the brother. My husband does not believe in psychiatric treatment, and he is not going to help. So I have brought him, and I'm only going to manage this and take this through because I have no help or support from my family. And the father doesn't even want to come and find out, or the mother doesn't want. I mean, there's one parent that is not interested in the treatment. So you have mutuality versus isolation. Next slide. Then you have families which are very flexible. So they are open to suggestion, they are open to change, they are very open to all the behavioral exercises you give them. They are working towards modifying the family environment to help the patient get better. And you have rigidity. So you tell somebody that, your son is ill, please do not focus on academics. Your son is ill, please do not focus on job. Let him get well first. And the rigidity is no, he has to work 9 to 5. He has to earn. He has to finish his 10th. He has to finish his 12th. He has to get 90%. So there's a lot of rigidity. Now you've given him medication. He's not able to get up. There are problems. No, he has to get up at 6 a.m. for yoga. He can do yoga in the evening. No, but there is a rigidity with regard to that. He has to eat this for lunch. He has to eat that. So there are a lot of families where there's a lot of rigidity and inflexibility. There's so much of, dependence that no, family rules are family rules and they have to be followed. Next. Then we also see families where there is role conflict versus role awareness. So you have some families where there is a role reversal. The mother is the earning member. The father is at home. The father is very timid, the mother is very dominant. We have some families where the mother is very timid, the father is very dominant. And there's an entire role conflict. No one knows what they're supposed to do. There is an elder sister, there is an elder brother who has to take on the paternal role. There's an elder sister that has to take on the maternal role rather than being the sibling. So there is a role conflict that often happens. And of course, there are families that are very aware of the roles that they have to play. So they are very, very aware that, yes, I'm the mother, I'm the father will manage this, the mother will manage this, the roles and duties are very well assigned, and it becomes a very easy family to deal with. Next slide. We also have families where there are intergenerational boundaries. What I mean by intergenerational boundaries, are the grandparents are very aloof. There's no communication between grandparents and the parents, grandparents and the grandchildren. Parents and children are very aloof. And the patient comes to you and says, I'm not very close to my parents. I don't communicate. Their thinking is different. My thinking is different. There's a huge generation gap which is present. And these are what we refer to as intergenerational boundaries. Next slide. And there are also need for leadership models in the family. So sometimes you have the mother who takes the leadership role. Sometimes you have the father that takes the leadership role because the other family members are weak. And this one family member then has to bear the burden of taking on this role and, moving ahead. So we do need strong leadership models in the family. And there are families where there is no leadership model. So the person who's coming for treatment at the age of 25, 26 has never really had someone to look up to, has never really had a role model, a paternal or a maternal role model to look up to. And they have also not had other surrogate role models. So it becomes very difficult in that state. Next slide. And communication patterns that matter. So there are families where there is sound communication pattern, and there are families where there is sarcasm, there is taunting. There are families, of course, where there is only fighting that happens and only aggression that happens. So those families then become difficult to deal with. Next slide. So there is also something what I refer to as task accomplishment issues in family therapy. So a lot of them are not sure what they want from therapy. So they very often come from therapy saying that help the particular person who's affected improve, but no one really wants to take up the task to sort of modify the home environment. No one really wants to take up the task to sort of help the person in his day-to-day chores and help him improve. No one really wants to take the task of working towards improvement of this individual. So there are a lot of families where task accomplishment issues are there. So even different life stages, different tasks have to be achieved. There's a lot of problem that is faced, and these task accomplishment issues often go unfulfilled, and the tasks are accomplished, and there are a lot of problems that develop as a result of that. Next. And as I told you, there are sometimes role problems. So there is maternal dominance if she is the primary earning member, and she believes that the father is not sort of part of the environment, and she believes that no, the father has no role, I am earning. So there's a role reversal and there are role problems. So this leads to a lot of conflict. Sometimes it can happen that there's one elder child who's looking after the entire family. Both the parents are either retired, or one parent has psychopathology, one child has psychopathology, the mother is very weak, and you have one child who's earning. So there's a lot of role conflict that happens. Next slide. And there is one family member who's supposed to be what I call the family scapegoat. This very often happens. Everybody removes their anger, everybody removes their frustration, everybody gets violent sometimes with this person, everybody says whatever they like to this person, and this person is very mild, meek, and he's often the patient who's coming to you, and he says that for years he has, borne the brunt of everyone's frustrations, anger, aggression, etc. So he's been the scapegoat child of the family. Next slide. And we see in some cases that come to us, we also see somebody who I refer to as a family martyr. What we mean by this is you have one elder sister, or you have one sibling, or you have one relative, who says, I am, or one, brother of the patient who says, I have not got married. I've spent my whole life only looking after my family. I've spent my entire life trying to, help my family improve. And I've sacrificed my own job. I've sacrificed my relationship. I've sacrificed this. And in the end, they are not happy because what they wanted to accomplish has not been accomplished. So they'll end up with depression also finally. So that is what we refer to as a family martyr. Next slide. Then we have some family members where we have one member who's sick. Now, what we mean by this is we have one family member with dementia who's, sick, and therefore everybody has to be running around him. We have a semi-bedridden patient with a stroke, psychopathology also. We have Parkinson's with psychopathology. We have families where you have somebody who has schizophrenia or depression or anxiety, and we have also somebody with a medical problem. So you have one family member with stroke, one with a kidney disease, one with a psychopathology. So these are families where there's a lot of problem because there are multiple members who are sick, and the caregiving roles are also difficult. Another area where family issues come up is in developmental disabilities, because this is an area where I work with a lot. And bringing up a child with developmental disability is very, very difficult. And therefore, sometimes the entire family has to play a role. So the mother, the father, one sibling. You have a sibling that is absolutely fine and feels neglected and feels that the child with developmental disabilities is given more attention. The parents also give more attention to this child. Sibling rivalry develops. The parent-child relationship with the child that does not have disability worsens. So multiple issues come up here. Next. And of course, there is something that I refer to as a parental child. We often see a family where we also see a family where the parent, when we say parental child, what we mean by the parental child is that one family member, one child rather takes on the parental role. And when I mean takes on the parental role, what I mean by that is that this person has to take on the role of looking after the parents. So we have a child who's in 9th or 10th or 11th, and he's managing the father who has alcohol dependence. He's managing the father who has schizophrenia, brings the father for follow-up. So this child becomes a parent in these families. Next slide. So in most people who come in for family sessions, the major issue is one of communication. There's a lot of assumption. There's an assumption that, you know, the other person has to look into my eyes or look at my face and understand. And this is a very big problem. And I tell a lot of my patients, you have to speak. In Indian families, I've had parents who come and say that we are married for 20 years. How come he still doesn't understand me? Because probably you don't express yourself as often as you should. You should speak. You should talk. Only when you talk will the other person know you have a problem. If you don't talk, how will the other person know you have a problem? You may sometimes have to get assertive. There are families where we have what we call the double bind problem. The mother and the father think differently. So bringing up the children therefore becomes a big problem because the mother has one viewpoint, the father has one viewpoint. The mother wants the child to get educated. The father believes life skills are more important. The child is confused what I should do. And double bind theory was an old theory that was proposed in the genesis of schizophrenia. And we still see it in our practice. When we see patients with schizophrenia or depression, we see so many times that both parents have diverse views. The father says, do whatever you want to treat the child. The mother says, I don't want to give psychiatric medication. I do only want therapy. We know therapy is important and it will work, but it will need to be supported, maybe pharmacologically, but no. And then sometimes even with treatment compliance, there's an issue because the mother doesn't like a particular therapist, the father likes a therapist, the father doesn't like a particular therapist, mother likes. So there are multiple problems that come up because of this. And the patient suffers because of diverse views. He gets confused. Next slide. And what also happens is there are families where families have to adopt. We see a lot of families where they are open to change, which we refer to as morphogenesis. They are open to change. As time progresses, they want to get digital, they want to change, they want to move with the times, they learn to accept things how they are. And we also have families that do not change and get stagnant. And we have people who come to us, patients who come to us and say, my parents do not want to change. They are resistant to change. They do not want to have any kind of change. They have to do this on Saturday, Sunday means they have to do this. They are not flexible. It's a family rule. If I have to do this in the morning, I have to do this in the morning. They are after me the whole time. So that is what we refer to as morphostasis, where the family doesn't want to undergo any change. Next slide. And then there are some families, what I refer to as steady state families. Everything is supposed to run smoothly. They do not like any kind of disruptions, whereas in life, disruptions are going to happen. There is nothing like steady state where, you know, nothing can go wrong. There are families that believe everything has to move smoothly. They want a quick fix. They want a quick cure. They want everything to be the same and no changes to happen. So those are what we refer to as steady state families who believe as long as things are going on, let them go on. We also have the next slide. We also have somebody in the family known as a family angel. So the family angel is usually one relative who's the angel figure. So the patient says, there is one uncle only who understands me, please talk to him. There is this one cousin of mine who understands me, please talk to him. And this family angel, or it could even be a family member who tries to take care of everybody. He tries to keep everybody happy and in turn suffers a lot because it does take a toll on him. So that is what happens. We have a family angel also. Next slide. And in family sessions, sometimes we may have to have what we call network-based family therapy. Now, in schools, sometimes, you know, we end up talking to even the teacher. we end up talking to the principal, we end up talking to. So similarly in family therapy, if there's a particular neighbor, particular aunt, particular cousin, so the family network beyond the family may have to be involved, and that is what we refer to as network-based family therapy. Next. And we have the most important factor in family therapy, which is referred to as triangulation, where very often the child is in the middle and the parents are fighting. And the child has to convey messages. The child is the one who is the communicator. The child has to be the judge. The child has to be the one to decide who's right or wrong. Either way, he's going to get into trouble, because if he decides that the mother is right, the father is going to go against him. If he decides the father is right, the mother is going to go against him. So the child is in a total confused state of mind at that point of time. And at a time comes at 18 or 19 where the child tells the father and mother that this is your problem. You deal with it. I'm not going to deal with it. And separation between the child and the parent happens at that age. Next slide. There are also two older concepts. One is what we refer to as marital schism. And when we mean by marital schism, there is a divide between the parents in this family. Their marital life is not good. The mother and father are not close to each other. They're not thinking on the same lines. They do not want to sort of, look eye to eye. They do not want to sort of look this thing. So what is very important is there's what we refer to as marital schism. There's this divide, and it's very visible. The parents do not talk. The child knows there's an emotional turmoil in the family. There's no love and affection in the entire family, and that affects the upbringing of the child, who often comes to us as a patient. Next slide. We also have marital skew, where one family member is dominant. We have so many patients who say that I can't go against my father. Whatever he says is final. I can't go against my mother. Whatever he says is final. And my father is very afraid of my mother, or my mother is very afraid of my father. All of us are afraid of him. Nothing can be done. So you have dominance. One partner that is highly dominant is a decision maker, is an earning member, and decides everything that will happen for the family, what we refer to as marital skew. Next slide. And there is mystification. A lot of parents build false realities around their child. They give a distorted view of what the truth is to the child, so that the child embraces that. And this they do to cover their own misgivings. They will blame someone. They will paint a bad picture about someone. They will tell the child, don't trust these people, don't do this, don't do that. And they'll contort the mind of the patient, of the child. And this very often happens because they want to avoid their misgivings. They don't want that their mistake should come forward or their failure should come forward, a phenomenon which we refer to as mystification. Next. And there is something called the rubber fence phenomenon. So there are a lot of family members who don't get into the fight. They sit on what we call the rubber fence, the fence which is, extendable. You can have people who, then they come in when they want, they go out when they want. So there's no proper fence. So it's referred to as a rubber fence. And there are a lot of people who are onlookers. He says, I don't get into my family matters. I just don't support anyone. I stay aloof. But then you're not having any family ties as a result. So this is also something that happens. Next slide. And we see what is called pseudo-mutuality. There are family members who will come to you, parents come to you with a patient, and they'll pretend to be a very closely knit family, saying they love their child, saying that they have no problems between us, they have everything that they want. But there is no closeness actually. There's a lot of anger and hidden aggression between their minds against each other, which is referred to as pseudo-mutuality. And I remember I saw a family once that came to me and they said, we are 4 members, we have 4 rooms, we have 4 TVs, we have 4 internet connections, we don't interfere with each other, we are very cordial. But in reality, there was a lot of hatred and anger that they had amongst all of them. And that was referred to as pseudo-mutuality. They'll click photographs, they'll go for marriages, parties, and pretend nothing is wrong with them. But there's a lot of problems that happen, and that's called pseudo-mutuality. Next slide. And we have pseudo-hostility. We see a lot of families that fight together. There's a lot of small fighting, aggression, anger, shouting, bickering, for that matter, arguing. They'll abuse each other, and the next moment they are fine and they're close together. So what we refer to as you may feel that the family is very hostile, but the family may actually be closely knit, and that's what we refer to as pseudo-hostility. Next slide. And therapy could sometimes be a facade. People come in saying, we want to undergo therapy just to show to the world that we're undergoing therapy. But they really don't want to change in the family. They don't want anything to change. And that's when we say that sometimes therapy may just be a facade to show that, okay, we're going for therapy. But they really believe that they can solve their problem. They don't need a therapist at all. Next slide. So it's very important that you need to explore in family therapy or sessions. And what you have to do is look at the family of origin experiences. What we mean by this is you need to go back in time and look at who the family of origin was. You need to go and see what does the mother bring to the table, what does the father bring to the table, how was their upbringing, what is that caused in their parenting, how has that affected their marital life, how has that affected their upbringing now. So there are multiple things, and how has that affected the way they feel. So the family of origin experiences is very important. Next slide. And the role of grandparents. Now, grandparents can be a blessing, grandparents can be a boon, or grandparents can be a curse. And we have seen all of this in our family sessions. There are some grandparents who believe they know everything. They say, we brought up children, we know how to run a house, we know how to manage. I don't think this is depression, it is very normal. And grandparents can impede treatment at times. But sometimes grandparents are very close to their children also, to the patient. So there are a lot of patients who say, I'm closer to my dada dadi or nana nani compared to my parents, because the parents are working and I've been brought up by my grandparents. So grandparents can be a very useful addition to families. We also have what we refer to as transgenerational transmission. And what we mean by that is the psychopathology transmits across generations. This we see in schizophrenia, alcohol dependence, domestic violence. And you need to find out about this, because it then gives you a pattern that there's accepted behavior which is being allowed. Aggression transmits across generation. Lying, cheating transmits across generations. So these are things which are there. Next slide. And the family life cycle, whether they are a new couple with small children, whether they're a couple with middle children, whether they're a couple with teenage children, whether they're a couple with adult children, whether they are a couple where child is married and there are two families living in the same house. So the family life cycle that they are in is very important also when you plan family therapy. Next. And ecological factors, whether they are living in a rural environment, urban environment, the kind of house they live in, the kind of space they have. So there are multiple things that play a role. Next. And there are epigenetic factors, because if there are genetic factors that cause problems like depression, anxiety, etc., there are a lot of epigenetic factors, meaning there are factors, environmental factors that affect the genes, and that also matters. So there are epigenetic factors which are at play also. Next. And the role of relatives. This is very, very important. You have a lot of relatives who are willing to give free advice, but are never there to cure. So they'll say, go to this doctor, go to that doctor, try this therapy, try that therapy. They will comment on your sessions, they'll comment on the way you're treating, but they'll never come to the front and help. They love to sit back and do what we call backseat driving, and they prefer to comment on multiple treatments. Next slide. So sometimes you can have couples that come to you in therapy and they also are a part of family therapy. So you have traditional couples, like we all see, husband, wife, children, etc., which come to you. So those are the traditional couples. Next. We see androgynous couples, where when we mean androgynous, what we primarily mean is that the female is a dominant member in the couple. So you might see this kind of a parenting couple that comes to you. Next. You may see avoidant couples, couples who are very distant from each other. They really don't speak to each other and each one is doing their own thing. Both are very busy, doing excellent in work, but they have very less time. Conflicted couples, couples that have a lot of conflict. They want to actually get out of the marriage, but they're only there because of the children. And this is what we refer to as conflicted couples. Next. And you have disengaged couples, couples who really don't talk to each other. So they say we hardly talk for 5 minutes a day. And I don't think we need to talk. We're very happy leading our lives the way we are. So they are disengaged, not emotionally engaged, not talking, nothing. Next. So couple therapy can also happen with family therapy. So sometimes you may need to talk to the family as a whole, and sometimes you may need to talk to the couple. Sometimes you may also need to have marital therapy, have marriage therapy along with family therapy. So this can also be there. Next. So we have multiple cases where you may have family therapy that may need to be done. One is newly married couples, particularly when there's adjustment issues that happen. The mother-in-law may have to be explained to this. Mother-in-law, daughter-in-law problems are very, very common. You have issues that come up. You have sort of new problems coming up with adjustment to life epoch. So all these things come up. So therefore, newly married couples are there. Next. And then you may have sometimes sexual issues in a newly married couple. The entire family comes saying that there's some problem in their marriage. The mother-in-law comes and tells you that I think they're not sexually doing well. You need to talk to the couple separately and look at sort of managing sexual issues, because the entire family is waiting for that good news to come, and nothing is happening. It's been 1 year, 2 years, 2.5 years, 3 years. So sometimes you may need to intervene in those cases. Next. And there are adjustments to delivery. So lot of families do not understand that the lady undergoes a lot of turmoil post-delivery. So postpartum depression, postpartum psychosis is very common, and that behavior is not understood by families. So the entire family may have to be spoken to post-delivery, particularly a working mother who suddenly have to give up work, feels lost, feels upset, feels hurt. So the family has to be educated about that aspect. Next. Cases of mental retardation or intellectual disability, the entire family is involved in the caregiving process. Psychoeducation about the disorder, explaining what it is, explaining about the prognosis, explaining about long-term vocational rehabilitation, acceptance of the condition, empowering siblings to look after the child after the parents. So these are multiple things that will come into play. Next. And the same goes for autism spectrum disorders. And this is very important because in autism, the acceptance takes a little more time because the child is sometimes intelligent yet having a problem. The child has normal IQ yet having a problem. So, and in autism, very often the cause is unknown. So it's very important that the disorder is explained to the patient. They should be told that they should not be seeking miraculous cures. It's very important that they adhere to the entire treatment regimen of OT, speech therapy, special ed, whatever is needed. So a lot of psychoeducation goes into that as well. Next slide. A lot of children that come to us with conduct disorder and externalizing behavioral issues in school, it's very, very important that the entire family is spoken to. And this is important because in conduct issues, very often parenting needs to change. The attitude of the parents need to change. The teacher and the parent need to coordinate. The entire family environment, if bad, if the father is having an alcohol issue, the mother is having depression, the child has conduct issues, the entire family may need treatment. So here again, you need to have family sessions. Next. And in learning disability, just like all the other disabilities, acceptance, understanding is very vital. Next. In cases of schizophrenia, I think family therapy is very vital because in India, not many patients understand schizophrenia as a disorder. Not many patients understand the prognosis. Not many patients understand what treatment constitutes. Not many patients understand the fact that it's a long drawn-out disorder. Productivity sometimes may be affected. Social life may be affected. Quality of life may be affected. The patient may prefer to be isolated. So, and they might want him to get normal. So the concept of normal in schizophrenia has to be explained to them. What's the concept of cure and normal? Next slide. Alcohol dependence. The entire family needs to be educated that it's a disorder. It's just not a habit. They have to all work towards seeing that the patient doesn't take alcohol. They have to all work towards abstinence. If you start disulfiram, they have to monitor it. If you start other therapies, they have to monitor it. So in alcohol dependence also, the entire family will have to be spoken to. Next. Particularly adolescent drug use, because this comes as a shock that 14, 15, 13, 16-year-old taking cannabis, vaping. The entire family needs to be told that their reaction to the substance abuse is paramount, because if their reaction is not proper, it can affect the child. The worry is we can't put an adolescent into a drug rehab where there are a lot of seasoned drug abusers, as the child may learn more and come back. So all these things are there. So even in this condition where there is adolescent drug use, there's a lot of understanding that the family needs to be given to. And it may stem from family issues. The child may take to drugs as a coping mechanism for depression, for not being understood by family members, for academic stress, for a failed love relationship. Multiple factors play a role. Next slide. Depression, of course, also has to be explained. Not many people understand depression. They think it's something that will easily pass out. There are family members who tell the patient, snap out of it. There are family members who say that you're just, doing this because you don't want to work, you don't want to do anything. They don't understand that depression is for real. So the entire family may need to be spoken to understand what depression is. Next. Homosexuality and LGBTQ+. In the entire LGBTQ+ spectrum, we get a lot of patients that come to us who tell us, please make our families understand that this is normal. Please make our families accept us. Or they come to us saying that we want to come out of the closet. Can you explain to our family members? We want to come out of and into the open about our LGBTQ plus status. Please explain to our family members. My parents have rejected me, they don't accept me, but I want my parents. So multiple times explaining to the parent that this is normal sexual behavior is our task in family therapy, and acceptance of the individual. Next. And in cases of child sexual abuse, because there's a lot of parental neglect that's happened. The child feels the parents never took me seriously when the child sexual abuse happened. The parents have turned a blind eye and thought that time will heal things. So there's a lot of animosity between the child and the parent, particularly if an uncle, a relative has been the abuser, and the patient is still seeing that this is existing. Then I'm seeing that abuser every day and it irritates me. And the father and mother have just not done anything. So this is something that also the trauma needs to be addressed. Next. And in terminal medical illnesses, sometimes you get a lot of people with dementia in the last stage. You get patients who are having cancer. The family may need counseling and need to accept the end of life care. So you may be called in to talk to families. Next. So there are other cases that come to us. We get the husband or the wife coming to us with suspecting the other partner has an extramarital affair. And I always say that, I mean, it's not our job, because it's not really a disorder. Okay, it's a social phenomenon. So we can only advise, but then sometimes they want to know, post the affair, everything comes into the open. How do we forgive, forget, move on? So sometimes the entire family may need help again over there. Next. In financial crisis, the entire family may need to be spoken to. They may just need support. So this is also sometimes that they come to you. Next. Death of a family member, sudden death of one family member, and the entire family is grieving. And we have done a lot of this family therapy in COVID, where the entire family has been spoken to after the death of a family member. So they've been taken through the grief process. So family-based grief therapy is something that also can be undertaken at this stage. Next. Children who are in the 10th and 12th standard, I think their families need to be spoken to the most. And we keep doing this every day. Particularly, I do it because I work in schools. So how to handle the child in the 10th, how to handle exam anxiety, how to manage tuitions. He must have free time. He must be understood. He's also hormonally developing. So there's going to be aggression, irritability, mood swings. How are you going to manage that he gets enough time to sleep, he eats well? Don't be after him. Don't be helicoptering him. Don't be irritating him. So there are multiple things about the 10th and 12th that, career decisions, multiple things that the family may need to be spoken to. Next. And sometimes career counseling issues, because there's a disparity between children and parents with regard to career choices. And they may again come to you and say that, please talk to the child, make the child understand, because these are things which are important. So this is also another area that may come into focus. Next. Sibling rivalry. Now, let me tell you, sibling rivalry is the most difficult condition to treat, because it starts at a very young age, remains up to adulthood. And it gets very, very difficult to treat, because the wounds caused by sibling rivalry remain lifelong. So it gets very, very difficult to, handle these cases. But sometimes you may have to get the siblings to come together and talk about certain things which are also there. Next. Yeah. There are certain difficulties in India. Like I said, to get all the entire family together is very difficult. It's a very difficult task. So that's one thing. Families are not open to coming together, speaking. They prefer to come individually. They do not like the concept of speaking in a group. Next. And there are reluctant family members. So they'll say, out of 5 of our members, 2 have said they don't want to come. We 3 are ready to come. Are you okay? So this becomes a very difficult task then. Next. And there are missing parents. So sometimes the parents are not there. One parent comes, one doesn't come. So this becomes a problem. Family therapy never really happens in unison. Next. And having children in a family session is sometimes also difficult, because the children come out with the truth and they sometimes blame the parents, and parents are not happy with children revealing what has actually happened. Next. Sometimes transference can happen in family therapy. One family member can sort of get a little transference towards a therapist. Of course, this will have to be handled. We all handle transferences in our clinical practice, and we can handle this. Next. The spacing of sessions is very important. You have to have it once in 10 days. You can't have it every day. You can't have it twice a week. Once in 8-10 days, so that they get time to go back, recoup. The session may be longer, it may be 1.5, 2 hours because all the family members have to talk. It takes a toll on the therapist. So the worry is also that should I charge more? Should I charge less? And I think if you're doing family therapy, you would charge more than individual sessions. Next. The duration of the session, as I said, is long. It's not 1 hour because everybody has to talk. Everybody has to get a chance to speak. It may be longer than an hour. In fact, you may give a small break and have a session again with the same family. Next. Should you have a co-therapist? Now, there are advantages and disadvantages. You could have a co-therapist of the opposite gender or same gender. And as long as you all gel together and think on the same page, it's very important. If you don't, then it can be a problem. Next. Sometimes if you have a co-therapist, there are disadvantages because the co-therapist may think differently. The advice given is different. Even when you have a co-therapist, sometimes you may be together in the same session, or you might substitute each other for sessions, but this can sometimes cause a disruption of the thing. Confidentiality is a big problem in family therapy because a lot of people come and tell you something individually and they don't want family members to know, but it needs the family to be addressed. So how do you manage it? So you will very often, and this is something which is difficult, and many a times we have to have family therapy and individual therapy together. So family therapy is going on and 1 or 2 members of the family are also taking individual therapy. So both have to go side by side. Next. Cost issues. Yes, it's costly because individual therapy plus family therapy, the cost does increase. So an entire budget has to be worked out for the family and given to them. Next. And sometimes you may have a couple that may, need to undergo therapy for their sexual issues and at the same time undergo family therapy for other problems. So this may also be done together. Next. And you have group family therapy, which is done abroad, where families are called together and spoken to. But in India, I don't think families like their problems coming out into the open. So group family therapy is not something which is in vogue. Next. Sometimes you may use humor in family therapy, but not everybody is receptive to humor. So you have to be careful what you say. The family shouldn't feel that they've been made fun of. Though you want to make the situation light, it shouldn't hurt their sentiments. Next. Sometimes it can happen that therapy may not progress, and that's what I refer to as therapeutic impotence. It just gets stuck. The family members come, they are fighting, they're arguing, and nothing happens. Therapy doesn't happen. So you need to lay some ground rules. Next. What school of therapy must I use? There are multiple schools of family therapy. I always believe that an integrative approach where you use multiple schools, an eclectic approach is the best. Next. Combination and integration. Yes, a little bit of psychodynamic, a little bit of family systems, a little bit of multiple other family therapy schools should be integrated. Next. Do Indian patients understand the nuances of family therapy? It's difficult. You need to explain to them what family therapy is. What are we aiming for? What are our aims? What do we aim to achieve? It's only when you explain to them that they'll probably understand. Next. And yes, it shouldn't be a sparring session. Everyone is fighting. It's a good chance for them to get at everybody and fight rather than, undergo therapy. So this is, I think, very, very essential. Next. And the family therapist also needs stress management because you can't be doing family therapy and it takes a toll on you mentally, it takes a toll on you physically, it takes a toll on you otherwise. So you also need to manage your own stress. Next. So to conclude, I think family therapy is tough, but it's something that can be done. We need to do family sessions more than family therapy. Next. You do practice individual therapy, but you can also try a few family sessions in cases where the entire family is receptive. Next. You may not be frequent, but see that the sessions are regular. Even once a month sessions are good. Next. Focus on specific issues. Don't be very grandiose and expect to solve all their problems. Focus only on specific issues that you can solve. Next. 2 to 3 sessions at the most, or 5 to 6 sessions max is what you can achieve. As long as you do that, I think you'll be fine. Next. It should be time bound and it could also be time consuming. So you have to see that it's done at best. And it's always been there in India. It's not that it's not been there. We've always been doing family sessions, which have been part of family therapy schools abroad, but we never really called it family therapy. We've called it family counseling. Next. Thank you. Thank you very much. And if there are questions, I'll be more than happy to answer them.
Thank you, Avinash. Right, would the moderators like to take over?
So we can have opening comments from the chairperson, then we can start the questions from the chat box.
All right. Ranjan, go ahead, please.
Yeah, thank you. So it's a wonderful session. I must congratulate Dr. Avinash D'Souza. So very briefly and pointed the poignant aspects of the family therapy, especially in the Indian context. So there are a couple of questions available. So I would like to ask those questions one by one. The question asked by Dr. Ankit Singhal, that families where they interfere the treatment are going to the faith healers, and the family are playing the role of bringing the patient to the faith healer in the initial aspect. So the duration of untreated psychosis is being prolonged. So here the role of family therapy is a bit controversial. The family, as per the Vaughan and Leib study, we know that the expressed emotion studies were there, where there's something positive regards, warmth are come as a good factors, and there's some negative connotations are already there, like hostility and critical comments. So here my question, modified by the question asked by Dr. Ankit Singhal. So what is the dubious role of the family therapy? At one end, it is helping out the patient, and at the other end, delaying the prognosis of the patient by bringing the patient to the faith healer. Your pick up.
Well, I don't think, in family therapy, we advise anybody to go to the faith healer. That's the family's call. So if the family goes and delays treatment, it's totally their call. In family therapy, we often explain to them that, yes, while we use religion and spirituality, we use it in a positive way. We tell them, if you want to pray, yes. If you feel prayer or, religious faith helps you, definitely. But we never recommend faith healing per se, because we know that it really doesn't work and there's no demonic theory which is at play. So there's nothing like that. But then what happens is, there are family members who prefer to do both side by side. We see that a lot in our practice. So we always tell them that, and what I normally tell people is, I don't want to hurt their religious sentiments. I always tell them, as long as the patient is being prayed over, or you're doing a havan or a puja, or you're taking him to dargah and being prayed over, it's absolutely fine. But please do not, burn him with rods or brand him or do anything which would harm the patient, or chain him or whip him. I mean, I would not want any human rights of the patient to be violated. As long as you're praying and it's being done in a very normal manner. I mean, like, a lot of people come and say that we're going to this holy place or that holy place. And I always tell them, please go. But I tell them, don't do anything which would harm the patient. So I always integrate spirituality and religion, but of course in a positive manner.
Right. The next question asked by Dr. Shakshi, the difference between the avoidant and disengaged couples.
So
Avoidant and disengaged.
So disengaged couples are ones that have had a problem and then they've decided it's better that we don't speak to each other. Avoidant couples don't want to have a problem, so they don't talk to each other only. That, if we talk, there'll be a problem. So that's the difference.
Question asked by Dr. Dushad Ram. Is family therapy indicated if there is no mental illness, but lots of family psychopathology is being present?
Well, I think we have a lot of families that come to us for general issues also. I have seen families that come to us where they say, we're just fighting and we're just irritable as a family and we want help. Or, I mean, for that matter, they are anxious as personalities, and they're just diverse personalities. They may not even have a personality disorder, but they don't see eye to eye. So you can give them sessions. There's no reason why you shouldn't.
The question asked by another question is that, do you recommend separation of couples in certain cases where the couples are incorrigible?
So it will depend on what they define as incorrigible. So, I mean, there are cases where there has obviously been violence and aggression and couples have hit each other. We tell them that, why don't you stay away for a week? You're fighting practically every day. So, give yourself some space. You can be in communication on the phone, you can talk, but just give yourself some space. I mean, you could both go to your parents' houses, or you could, one could go to the parents' house or whatever, and just give yourself space. I'm not telling you all to separate and not talk, but probably being in the same house is leading to a fight. You all both need space, and they very often come back because they get time to introspect, retrospect. They come in for individual therapy in the meantime. And then when they come for a couple session, they say, I've had a lot of time to think and I've realized that this is what has happened. So it does help, but I mean, it's not that in every case we suggest that, but in cases where there are problems on a very day-to-day basis and there's a lot of violence, aggression, the entire family system is totally disrupted, then yes, we do suggest.
So
Dr.
the
Avinash,
question, yeah, please,
Sorry.
please, Dr. Rukshala.
So thank you so much for those insights, really. Very often we'll have a primary client or a patient whom we are treating for whatever illness that may be. And then there is, of course, a requirement for family therapy, whether you're talking from psychoeducation point of view or from improving relationships point of view. And because we are human beings and we'll have transferences or we'll have biases, really. So a therapist might, and how do you deal with that? How do you navigate that space where the family might think that, oh, you're the therapist or you're the psychiatrist of this person, that's why you're taking their side. And how do you counteract those kind of blames or, that one might face in a session?
So I normally tell them, particularly if I've been treating a patient individually before, I always say that I'm not here to take sides, but I'm here for the well-being of my patient. So if I feel that there's something wrong and that needs to change, I will point it out to you. Whether you change or not, that's totally your perspective as a family. I can tell you that this is what you're doing wrong. Yes, if my patient is doing something wrong and disrupting the family environment, I'll tell him also. So I'm not here to take sides, but I mean, if the family already feels that I have a bias or they have something, then I always give them the option of letting the patient remain with me for individual therapy and going to another therapist for family sessions. And, and I will coordinate with her if needed. But otherwise, I say let the family sessions happen separately, and I will only treat the patient medically and with individual counseling if needed.
Thank you.
Okay.
Another point that kind of sometimes would you recommend and suggest that we might want to do this more often, that the therapist may be doing a family session, and because you may be a treating psychiatrist, should we join the session? What would our role be? What would be, who would be like the lead therapist or whatever in those sessions? How would we go about in that kind of a joint session?
Yeah, so this happens in around 3 or 4 scenarios. So one is the therapist working in your clinic says that there's a lot of sparring, bickering, arguing happen and the sessions are not going through. And me telling them is not helping. So maybe, you coming in for the first 15 minutes and talking to them as a doctor and telling them that we are facing roadblocks in your therapy because of this. And they listen to you probably. And so you going there for the first 15 minutes and coming back in the end to check on how the session went is something that would be helpful. That is one. 2, you could also be there when you want to address issues related to medication adherence, compliance, etc. And you feel family members have to play a role there. So, you could be part of the session with the therapist. You could also be part of the session when the therapist wants you to supervise and advise that, whether you feel the session is going properly. Or do you think I should need any modifications? And sometimes we have therapists who ask us that, sir, could you just sit for half an hour so that you could give us an advice on whether the line of questioning that we're using or the line of communication that we're using is proper or not proper. So that is one. And lastly, what happens is that the patient's family says, sir, we would, like you to be there for 1 or 2 sessions or at least come for some time. I think they probably feel you referred. So, you're the main person and they would want you to be. So I think in those cases, we do take part. It does happen. It happens even in individual therapy when we refer a patient outside. So it happens in family therapy also.
So one last question, very often, especially when we are doing couples counseling and there may have been infidelities and cheatings, and you may have spoken to the couple, the partners individually, and then you're also doing a combined session, depends on the flow of the plan. And if the one person who has been cheated upon will ask you directly, you've spoken to this person, tell me whether this person has cheated or not. How do you keep a poker face, not give out confidential information, but at the same time, because the express intent of sessions is reconciliation for them. So how do you get out of that sticky situation?
No, so I normally, whenever one partner admits, I always tell them that I'm not here to spill the beans. I'm very clear about it. So my job is to, help you all. And the thing is, I tell both husband and wife that there are certain things, if both of you ask me to keep confidential, I'm going to keep confidential, and you have to respect that aspect. Sometimes they may request for an individual session and inquire, and I always tell them, I think you need to have this conversation with your partner directly. Or sometimes I know the couple says that one of the members says, I think I want to come out and tell my partner that this has happened, but I would like to do it in your presence. So I allow that to happen, but I'm not the one who, conveys that, this is what has happened. I prefer not to be the one, because there are times when we have, I think people come to us with, printouts of SMSs, and they'll ask us, do you think this is romantic? Do you think this is sexual? Now, it's very difficult. And I always say, it seems like that, but it's not my job. I'm not CBI person, or I'm not here to, comment that the affair has happened or not happened.
Okay.
Thank you so
Okay,
much. With that, I'll hand it over to the moderators. Thank you.
Yeah, I think we are lucky to have Dr. Nanda today. He specializes in family therapy. So if you all allow, I'd like to invite Nanda for
Please.
his-
Sir,
Yeah,
I'm not
so-
a family therapist at the outset. I've just given only my views. Yeah.
Good
So
evening,
Nanda,
sir.
Nanda,
Good evening, everyone.
your overview on the topic, please.
Yes, sir. So thank you, Alim, sir, for this opportunity. So whatever the cases I have seen, family therapy, usually you have to deal individually also. Like mostly like the couples having a personality disorder, like narcissistic personality disorder. Recently, I am seeing like one couple along with the family also. So the husband is having narcissistic personality disorder, and the wife is having borderline personality disorder, and the two sons are having alcohol dependence. So they're all like 24, 25, 27, the sons. So the couple got a second marriage from a dating app. Okay. And they talk about couple swapping. So many things that is something like coming very easily. They are talking about all the things that should not be discussed. So the generation now they are discussing with all these aspects. So communication problem is there. What I do is that behavioral contract, so that everyone has to agree with what is the goal. Because as what Inash sir have said, the sessions goes for more than 2 hours. So you can't able to control them. So behavioral contract is that you can make that these are the goals, and we have to work at least for this coming few sessions. So that is one thing I used to do, because it's very difficult to control them. And next aspect is that they want a quick solution for their problem. So it's not like that you are focusing on their errors or their individual problem or depression or personality disorder. So they want a quick solution for that. So again, that puts a lot of as a taxing job for the therapist. So you have to be the presence of mind and come out with something. So again, that is modifying the communication pattern again. So that is something like an experienced therapist. On the go it comes, even I don't know that it comes something, and everyone will be happy. Okay, I think this is the thing we have to modify. And role play and role reversal is something like it has to be done in the therapy session itself. So we are coming out with some certain agenda. This is what you have to do in the homework. So something that has to be done in the session itself, the role play and the role reversal. And like what Sarah have said, that assertiveness training, those things also have to be involved in the role play. So these are, so individuals are depression, definitely. So the person who's not being rewarded or always been neglected. So that sort of the behavioral component. So we have to focus on. So focusing much on the behavioral component, something is very helpful, rather than focusing on the cognitive aspect. So that is something the thing. So, and so most of the cases I am seeing from doctors only, all gynecologists and all. So like mostly the personality disorder play a very major role. Like couples, like the in-laws wants even the wife's money to be put in their account, and they will give whatever the expenses she wants. So these sort of things. So both are doctors. They're having the hospital. In-laws is having, or also doctors. They're also working. So these sort of personality disorders very, very common. That is narcissistic personality disorder. So these are the things. So very challenging, and so behaviorally we can focus on them. Thank you, sir.
Thank you, Nanda. Any questions in the chat box that is left out?
I have one question which I want to ask, Alim, Amrit, and Ranjan particularly. I'm asking this for my own knowledge that, see, in major metros, like say Bombay, or Vishal will agree, in Delhi, families come in for therapy and they're open to the idea as well. But what I want to know is that in what I refer to as mini metros, I won't call them tier 2 cities, mini metros like Lucknow, or for that matter, Bhubaneswar, or parts of West Bengal, like where Ranjan is, are families open to family therapy? I just wanted to,
No, sir. They're not open. They just want to pinpoint it on somebody.
Lastly,
They
sir,
don't take responsibility
use
for
for sir,
things.
nitroglycerin.
If they tell that we have brought them here,
Points.
you deal with him. You don't have to
Correct.
deal with. And if you tell them more, they will just avoid and go to some other.
2.66.
section. So sometimes I think that to gain 100, we should not lose everything. 50 ही यदि benefit कर रहे हैं, benefit कर लेते हैं. मतलब I sometimes take that stand कि
Correct.
जो है कुछ तो दे के भेज दो. नहीं तो फिर अलीम के पास पहुंच जाएंगे. अलीम पूरा गड़बड़ कर देगा कुछ.
Actually, I refer them to Shazia, so I think much of the problem solved for
हमारे
me.
घर में ही पैसे रहते हैं.
So that is the thing. So basically for any therapy, if you provide results, people will come to you. So if you are not specializing in therapy and then you are attempting, because I see many psychiatrists, they are doing CBT and all these things, and actually they are not specialists in that. And
Correct.
because of a bad outcome, people develop a bad.
But where you don't have good psychologists, where you can't trust.
Yeah.
You know,
You have to have specialists. You have to have specialists for that field. Then people will.
I sent a patient of OCD, and this OCD patient had to a psychologist, clinical psychologist. I have utmost respect for them, but then she found out there was a sexual abuse when she was 13. So she told that you are trying to wash it off. So this will not go ever in your life. It will remain throughout your life. And I had to take her out, increase dosage.
Yeah, I can
How much can
understand.
you trust?
No, I can totally understand. Yeah.
Dr. Sakshi has raised her hand again. Dr. Sakshi, you want to ask something?
She wants to discuss a case, I think.
Yeah, good evening, everyone. I'm Dr. Sakshi and I practice in Patiala, Punjab. So I had 2-3 questions, if you allow me, if there's time. One was that pertaining to countertransference. I do not do family therapy as such, but yes, family sessions. So there was a couple. I had a young married female in 30s and she had RDD along with that panic disorder. And there was family conflict. So there was domestic violence and husband was not cooperative. He would not take her stand in front of family members. Now, currently, the current episode, it was exacerbated by sexual assault by the father-in-law, to which husband did not take a stand. And when I had the session with the husband in order to understand this, there were also other issues as well. There was sometimes the husband was sexting with other females and even the violence by him as well with the wife. So there was a lot of conflict in the couple. Now, the issue arose actually with me as a therapist because I developed countertransference to the patient when he literally gave a very lame explanation he said that his wife perceived that there's something happened. She thought, she felt. And I asked him to elaborate and I tried to be gentle with it. So I want to ask you that how to avoid, first of all, countertransference. And secondly, when there is a lot of discrepancy in the information, which is given by the family member or the other member is, blatantly lying and trying to give false information, which was then corroborated with the patient that it did not happen. She mentioned about the 3 to 4 discrete episodes to her husband, and he negated all of them, that she just felt it. So how to deal with that first?
Should I answer? Yeah. Yeah. Okay. Now the thing is, see, countertransference is very normal and it can happen. We're all human, and particularly when you have husbands who are violent and you have husbands who are aggressive, and it can develop because we obviously don't like this and we're not this and we don't encourage this and something that is against our ethos. So we will develop this. But I think at the same time, what happens is we have also to learn that everybody needs help. They also need help and they're also probably suffering because of their own problems. So we have to try and avoid it. And if we feel finally, no, we can't avoid it, then I think we need to encourage that the concerned person who we've developed a countertransference to seeks therapy elsewhere. if we are not able to manage. But it can't happen that we let our personal aggression, bias, counter-transference, etc. interfere in, you know, their reconciliation. Like there are couples even after domestic violence who can come together. There are couples who even after an extramarital affair come together. So just because, you know, I feel that, you know, how dare he have an affair, we can't develop our counter-transference towards them. And I mean, as men, we have our biases, as women, we have our biases. So it's a very normal phenomenon and this will develop. But I think what's very important is we have to recognize it. So if you do recognize it, then you need to take steps to sort of, you know, take care of that.
Can I answer for that?
Sakshi, if I
Yeah,
may.
please. Yeah.
Yeah,
I mean,
so,
whatever.
yeah, so counter transference, basically, ma'am, transference, counter transference, all these things, resistance, all these things happen. So if the therapist is having any sort of negative or a positive counter transference is feeling happening towards the patient, so you just journal it down, you just document it. What is that? So definitely it is your schema or your core conflict that is being brought out in the therapy. So it is like the therapist also evolved during the therapy. So that is a good opportunity that it has been pinpointed or you are being triggered by that. So just documenting during the session itself, and later on you can able to work on that. So that is how you can able to means overcome those counter transference. So it's a process, gradually it will happen. And definitely in other situation, it can't be triggered. During the therapy situation, it will be touched. So better you document and you identify what are the cognitive error and the schemas. So only particular thing that will be themes will be eating. You can easily see in the sessions itself. Thank you.
Dr. Sakshi, I do not envy you your position, unfortunately, because when we are dealing with situations where the abuse is either continuing, and especially if the abuse is coming from multiple sources, whether that's sexual, physical, verbal, and every abuse is psychological and emotional, to then continue to try and support the therapy goals of either the couple or the family unit for reconciliation can be very, very challenging. And just like Dr. Ananda also said, that if you think that you're getting triggered, or your conflicts or your schema, you know, all of that is interfering, then it might definitely be a time for you to probably either take a step back, refer them to somebody else. But also if there is something that you feel that there is more, you know, it's very dangerous and the person is in danger, we definitely have to document and then maybe discuss options and suggest not in terms of like, oh, you should leave or you should do this, but definitely suggest that, okay, you need to be able to protect yourself and you need to be able to feel safe in those environments. And again, like I said, those could be difficult spaces to navigate. And yes, there is usually a risk of losing the client, but I don't think any of us are really afraid of that, because our ethics of causing no harm is going to surpass the other hesitation we might have. So best of luck with your case.
One thing I like to add in that, Kshitha madam. So when you start like, okay, I'll avoid this case, I'll move to some other case, I'll refer to someone else. So actually what happens now, you are avoiding it. So we say no, in behavior therapy, we should not avoid the thing that you have identified. So better, like if you think that you can handle it, it is something, a moderate level of the issues that have come out. So you can, as ma'am have said, so you can discuss with the senior people and you can just continue so that even you can able to rectify those, the conflict that you are having it. That's my suggestion.
Very briefly, I'd like to ask Dr. D'Souza as well as Dr. Nanda. So there is a term called transgenerational psychotherapy. So here it is modified from the family therapy. The 3 generations are being they've been counseled together in a single setup. So what are the indication of the transgenerational psychotherapy and how much effective it is?
I think Dr. Nanda will answer. It's not my area of work.
Sir, after you, sir.
No, I have not done this kind of work. I know what Dr. Ranjan said. That's the definition that I know, but I have not really worked. So please, sir, please answer.
So theoretically, I am not able to get what actually is explaining that.
No, so I think what he's trying to say is that when you have three generations of the family, like say grandparents, parents, and the children, all in the same session. So the school of therapy is referred to as transgenerational family therapy, where we have the three generations, and of course, certain disorders come across generations. But I mean, I've not really had that kind of experience. I've generally had only parents and grown-up children and others who come. So I've had grandparents with small children, particularly with ADHD, learning disability, and that not really with adult psychopathology. And I think it's been more of a parenting approach or more of an acceptance approach where I've had this kind of a thing. But I've not really worked from a transgenerational perspective, so I don't think I can comment.
So, to me, basically, like only nuclear family are coming, not like what you are saying.
But if I can add,
Okay.
Rukshita, yeah, you go ahead.
Well, I do have some amount of experience, so that's a very commonplace. But I think depending on, again, what the therapy goal is of the individuals and how maybe you also help them set those goals. But the common spaces would be, okay, these are the words or expressions or language or volume or tone which are undesirable. This is how we communicate with each other, because even kind of aligning similar language across three generations, especially when we see so much of change in the Generation Z or Generation Alpha, can be rather challenging and tasking. What the younger generation would think is normal would be considered badtamizi or disrespect from the third generation, from the eldest third generation in that sense. So essentially, the first few sessions would just be about, okay, these are the words that are acceptable. These are the words that might be, even if you don't think they're disrespectful, but avoid using them because they could be triggering to the other person in that sense. Again, like I said, depends entirely on the family, on the therapy goal that we are looking at. If you're looking at parenting, very often, even in nuclear settings, the grandparent is the de facto parent. So they're, playing dual roles in terms of parenting as well as grandparenting, in terms of babysitters, but also, second primary plus care provider. So the relationships and the functions and functionalities of individuals are also blurred. So again, maybe some kind of drawing boundaries in terms of who's in charge of what, who like, if this one says no, can I go to that one for permission? And who has the ultimate say in this aspect of the child's life, especially, or who takes a call and takes the lead in maybe taking these kind of decisions. If you help them navigate those and come up with their own set of boundaries that fits and aligns with their family subculture, I think those would be more groundbreaking and facilitate conversations and communications for years to come, instead of only trying to kind of like do one particular thing. So I would suggest that if you're working with three generations, nothing wrong with it. Very great, especially if all of them live together and share common space and also help each other and are each other's caregivers as well. Because the role reversals are very, very common and very interchangeable when you're looking at a transgenerational setup. Those would be my inputs. Thank you.
So just one thing, like what I've observed, I haven't done completely, negative modeling is being seen. Like the grandparents, they used to like fight. So the parents also does the same thing. And this case I have seen in Haryana. So it's like beating the wife is something like it has to be done. So it is coming from the generation. So the grandparents also have done. So they refer, like they also do it's normal in our culture and at home. And the person is also doing. The current problem is that the son, who is 15 years old, now he started to beating the wife, means mother. So not only the husband, so now the son is also beating the mother. So these are something negative modeling that I've observed from the generation it comes. So that's one input I'd like to say.
I think we have covered all the questions, Amrit, Vishal.
Yes.
Yeah, all covered.
Avinash also has to go. He is last minute. He told I'll go at 9.
So Tufan sir, any comments from you? Then we can wind up.
Thank you. Thank you very much, Avinash, for your lucid presentation. And a formal family therapy, as in textbook, will be different from what you told, but what you told was the reality. and that you always do formalize. I would like to respond to two things. The question you asked to all. What is the status of family therapy in other places, not necessarily other cities? If you dilute the definition of family therapy, talking to family for a problem, we have to do it. It is not for 2 hours, it may be for 10 minutes, 15 minutes. If the minuscule version of family therapy one has to do when a chaotic child has come, even when there is a question of taking care, one has to talk to parents. So, but if you go for a formal psychotherapy or sessions, 2-hour sessions of psychotherapy, mathematically calculating that it's not possible in many of the places in India. The demand and the number of psychiatry or psychotherapist hours available do not tally. In this background, I have a question. That is the question, not to answer that. Do you have any idea about AI assisted or chatbot assisted family therapy, which we are having in different ways? It is the talk of the day.
No, sir, not yet. I think chatbot assisted individual therapy definitely in big ways, but I don't think maybe the chatbot will get confused if the entire family is talking.
But there are two things about chatbots. I think LLM models, there are two things. Chatbot can treat. Individual, I am depressed. I have got a chatbot. Hello, me, I have asked her to treat me. Okay, Elomia treats me. But I go to Alan D'Souza. Sorry, I go to Avinash D'Souza. And Avinash D'Souza treats me, taking help of Elomia. That is a difference. And that is what is being advocated nowadays.
Okay, I have no experience in this thing.
Because you are from Mumbai, the place where it's happening place, I thought you can enlighten me that. Okay, thank you very much. I was just...
Sir, I think we must all congratulate Rukshita on Sunday. She's going to become the Bombay Psychiatric Society president. We will not get a chance to see her online, all of us together. So that is the thing.
Okay.
Thank you so much.
Congratulations. Congratulations, Rukshita.
Yes.
Thank you.
All the best. Congratulations. All the best.
Thank you.
Congratulations.
Of course,
Congratulations.
I will allow all of you all to make up for the fact that you all are not here to help me celebrate my day. And individually, I expect a lot of gifts and treats to buy my forgiveness.
Sure. Please send us I'll send my PhonePe number. Please send us money to get you gifts and also gift ourselves. Because one of our friends is going to take over as president.
Thank you so much for all the love. Thank you, Avinash.
Yes, bye.
Thank you. Thank you. Amrit, over to you. You can thank me.
So first of all, I'd like to thank Avinash. You know, at 6:45, I give him a call. And in 3 minutes, he tells that I'll call you in 5 minutes. And in 2 minutes, he calls back and tells that topic. Topic hai. In 1 minute, again, he confirms and tells me that send me the flyer immediately. Immediately, I was in another meeting. I called up Ali and told, make the flyer and send immediately. So, the whole the system is working. That's very important. And we had a session where we were thinking that we'll cancel it. 99% chance was we were going to cancel it. But we took the 1% chance. So we have the all-weather friends with us always. So we thought, let's do something. Something is always better, even if it is not too much into family therapy, but we had a revision of family therapy. We had it, we can't be family therapists, but somewhere we can understand where the problem is, when to refer, how to deal with certain things. And I think Avinash did a wonderful job here. It was too good. He had no time. He was telling me 8:45, 9. I told, "Aajo ek baar phir soch." Itna tak khiste hai. So that's great. And we have, now we have a very good team behind us. Aleem and Vishal are doing great job. Tufan sir, he just landed from Calcutta. He had his visa interview and is still into it. We had my dear friend Nanda. Oh, with all seriousness, not such a serious person as he looks like. He's all fun. And Ranjan was today quiet. I don't know why. He's busy in IMA affair. Rukshita as always. Great. So it was wonderful. We had a lot of questions. We were good as a team. We were good today. So we all should congratulate each other and let's try. Let's help Rukshita also. She'll be next one will be president. So we're all there with you. So thank you again. Thank you to the Musings team. Thank you to all our viewers. We have more than 200 logins today, peak of 146, 47. That's not bad. We had another 2-3 programs. We had a East Zone meeting today. We had a TA meeting and whatnot. So thank you and good night, everybody.
Thank you,
Have a
sir.
wonderful weekend.
Thank you.
Congratulations.
Thank you.
Thank you. Best wishes, Ukshita. Again,
Thanks.
best wishes.
Congratulations.
Bye-bye.
Thank you. Bye-bye. Good night.
Good night, everybody.